सो नाउ यू आर गोइंग, ये जितने भी ड्रिल्स हैं ये कभी टीचिंग में आते हैं, कभी आपको सिमुलेट करना होता है ड्रिल, ठीक है। सो अभी जो है, जो दूसरी नाइला है हमारी, आप यूट्राइन डिवास्कुलराइजेशन ड्रिल को जो है टीच करो। स्टेप वाइज यूट्राइन डिवास्कुलराइजेशन ड्रिल, टीच योर ST1। आप कंटिन्यू करो टीचिंग, आई एम जस्ट लिसनिंग, ओके। इधर गई नाइला, दूसरी वाली नाइला
यस
बोल।
मैम।
हाँ
जी
बोलो
जी,
शाह।
अस्सलाम
शाह,
वालेकुम।
वालेकुम अस्सलाम।
हाँ, मैं अभी पहुंची।
ठीक ठीक है, स्टार्ट
जी,
करो।
स्टेप ऑफ डिवेस्कुलराइजेशन, मतलब कि वो टीचिंग स्टेशन है ना।
यस, इट इज अ
um,
टीचिंग स्टेशन, कंटिन्यू।
Assalamu alaikum. I'm Dr. Naila, one of the exam candidate. uh, Assalamu alaikum. I'm registered here in a ward, and may I know your name please? uh, So you
कंटिन्यू।
want to learn about the uh, steps of the devascularization, uterine devascularization. Is so far? Yes. May I ask that why you are interested to learn about devascularization, uterine devascularization? Yes, ma'am. I hear a lot of the time seen in case of the PPH, but how it is performed, I don't have never seen. Okay, I will tell you about the steps of the devascularization. So, it is an obstetrical emergency, and it should be performed by the senior consultant and team of the work, including the surgeon also. So, it is a very interesting topic also. So, I will tell you, and at the end of the session, you will able to learn, and I will provide you some material and video links that you can learn a lot. Okay, yes. So our objective is that what are the steps and how it is performed, and why the uterine devascularization is recommended, and what are the complication of it. So once the it is should be performed in the uterus model. So first we have to, once the already abdomen is open, and the indication, first we use the indication of the uterine devascularization and the equipment and setup. So first we need the equipment, we have opened the abdomen, skin, fascia, and then deep fascia, superficial fascia, and fat, and then peritoneum. And once the we recognize the uterus and the uterine artery is there, so we have to palpate that, and we take the suture like a manner in a straight with a needle, needle wo bilateral, and then we have to ligate the uterine artery. So after this should be performed by the surgeon and senior surgeon and assistant and a scrub nurse, and the patient should be anesthetized. So what are the indication? Uh, uh, you want to ask any question? Okay, so you can ask me and confirm the indication. So we have to confirm the indication for the uterine artery devascularization. So including the indication, main indication is the PPH. So persistent PPH, either the primary PPH or the secondary. But in primary PPH, once we have opened the uterus, and we close the uterus, and there is bleeding is running, and bleeding will not stop. So uterine artery devascularization is the first step in a surgical laparotomy. So it is the first measure which will be taken. Okay, you got it my point?
यस
Yes.
यस।
And so resuscitation, along with that, we have to resuscitate also the patient, because uterine artery is the vessel where the bleeding is, severe hemorrhage is there. So it is a very obstetric emergency. So the key statistics of the uterine artery devascularization is considered after the failure of the medical treatment and Belench suture. Okay, then 5 to 10% patient have uterine artery devascularization can be done. So how to expose? First, we expose open the abdomen. Already I told you, and then we have to check the bleeding site at the uterine tone, and then after externalization, so uterine artery we have to ligate bilaterally. First on right side, then on lateral side, and then after that we can ligate the uterine artery. So identification is very important. Below the uterine artery, there is a ureter. We have to check the ureter also, and ureter can be avoided by ligating the uterine artery. So it is at the level of the isthmus. So grabs the broad ligament like a patient with a forceps, avoiding the ureter, and then place the absorbable suture through the myometrium and avoiding while the uterus, and tie securely. And the success rate of the uterine ligation alone is effective, maybe 75 to 80%. And then any question we want to ask? Okay, you are with me? Okay. Then ovarian artery ligation. If bleeding persists, still not controlled, then we have to devascularization not only of the uterine artery but all the vessels. First uterine, then ovarian, then bilateral internal iliac artery, then ovarian artery that is ligated if the bleeding is persistent, and we have to proceed for the ovarian ligation. So identify the uterovarian ligament, and then suture is placed through the mesoovarium and lateral to the ovary, and then we have to tie and secure the blood. And then success rate of this is the both uterine and ovarian artery is up to 85%. So then unilateral or bilateral internal iliac artery ligation is the third component. So it is the if the bleeding is still uncontrolled, and internal iliac artery may be considered. So internal iliac is identified first, skeletonized, and then double ligation is there. So this step is rarely performed, less than 5% of cases, and it's a technically it is a challengeable. And then the success rate of internal iliac artery ligation is the successful up to 40 to 60% of the cases where when it is performed. And then we had to assess the hemostasis. Fourth step, hemostasis, how to check. If hemostasis is achieved, we have to check the ligatures also. And if not, then considered. If still there is a bleeding, then we last resort is the hysterectomy. Then close the abdomen in a layer and leave the drain inside if needed. And then post-operative care, we have to manage the patient's vitals, shift the patient to high dependency unit also. And uterine tone, if the uterus is preserved, then tone can be every 50 minutes, should be checked for 2 hours, then hourly. And then monitor the vaginal bleeding and a wound site, and administer the uterotonics in the form of the oxytocin, misoprostol, carboprast is needed. And after that, we had to check the all these things, and then after monitoring antibiotic, fluid, and painkiller, and then early mobilization, and then डीवीटी के लिए भी हमें देखना है कि वो असेस करके हम उसको हेपरिन भी स्टार्ट कर सकते हैं, वो भी लगाएंगे, और उसके बाद जो है हम उसको वॉच करेंगे फॉर द कॉम्प्लिकेशन. ठीक है, क्या क्या कॉम्प्लिकेशन कौन सी सकती है, उसमें इन्फेक्शन है, एंड एंडोमेट्राइटिस, वुंड इन्फेक्शन, and 5 to 10% is patients में हो सकते हैं. And then hematoma or rebleeding can occur 2 to 5%, and ureteric injury is less than 1%. And then counseling the patient, debriefing, documentation, and duty condor, and then incidence of the PPH and recurrency, devascularization success. I have told you already And then after that, clinical governance, 7 Ds we have to fill.
Very
Okay,
good.
you
Very
got
good.
it, my point. And then we counsel the patient, and the next for the